Squat. Posterior pelvic tilt in the squat. What is the first thing we would try and do? We did squats earlier this morning. What's the first thing we would try and do before we try anything else? Yeah, we try and coach them out of the problem. Easy, fixed straight away. Or not. What's the second thing we would try and do? Fix their motor control. Yeah? Sitting on that box, hovering off the box, wow, look, you can now do a squat with a neutral pelvis. We teach them how to do it. Not just the coaching cue, but teaching them how to do it. Teaching them the skill of squatting with a neutral spine. If you can't do that, then that's when we need to start looking at the movement therapy because of some sort of underlying musculoskeletal dysfunction. And that's where we can go a little bit deeper with this and look at distraction at the hip. Look at what might be tight, weak, loose, overactive, underactive. And again, a lot of factors going on with this posterior pelvic tilt. That's the one that I said I've got some other resources to send you guys through so you can read and absorb that if you tick that as one of your items. Knee valgus, knees falling in. We've identified the problem, we've assessed the problem, the knees are falling in. What could be tight to cause that? Whatever pulls the knees in. Who said that? Perfect. Whatever pulls the knees in. For bonus points, what muscles could that be? Broadly speaking, adductors. Okay? So how do we, if these are too tight and too overactive, what do we do? PNF, what does it look like? Lying on the back with the knees out. Yeah? Do you guys see how we're like starting to piece bits together from the different modules? It's starting to come together and you're realizing that you remember a lot more than maybe you thought you were because we've gone through a lot of stuff. It's been a long day. So we're killing it. What is weak? Underactive. Abductors, anything involved in pulling the knees out. Okay? Glutes, glute medius maybe in particular. Let's go back to when we talked about stability, because this fold is a really good example here. We talked about stability. If mobility is the ability to create movement, what is stability? The ability to resist movement. So if we want to work on the knees being able to track out more when we squat, we're trying to resist this movement. So we need to apply an external force that's going to pull our knees in. Then we need to fight that. Because the act of fighting it by definition, the act of resisting this force creates stability. How do we do that? You put bands around your knees. Okay? And doing this, lying on the ground doing this sort of thing, I'm not saying there's not a place for it, but I don't believe there's as much a place for that as there is a place for putting a band around your knee and squatting, because it's specific to the skill you're doing. Your feet are planted on the ground. The more we can match your therapy, your movement therapy, with the position that we're trying to fix, the more applicable it's going to be to that position. And I don't think many of you would argue with the fact that a squat is more usable for exercise, athletics, longevity, life, health, than doing this. Not to say that that's not a bad thing. There are no bad exercises. Just like your guys' journey this weekend, it's a continuum. I believe, and some people won't agree with me, and that's cool, I believe that squat with a band around the knees sits further up the continuum than doing this on the ground.
If someone does have knee valgus, would you get them to do it as a warm-up and then take the band away, or would you have them do it under load?
Yes, those things.
So both, everything.
All of those things, yeah, and different combinations of it. But definitely if they're underactive, they're doing squats with a band around the knees activates it, you then take it away, those muscles are all turned on. Our spinal cord, when we wake up in the morning, we've got nerves coming off all these levels of our spinal cord. When we wake up in the morning, each of these little nerves has got a volume knob on it. And that volume knob goes from 0 up to 10. When we wake up and everything's pretty asleep, they're all set on about a 2. Which is why when you wake up, you can't like squeeze and make a fist. You probably can't go and PB your deadlift within 2 minutes of waking up. You got to turn those muscles on. So doing pre-activation stuff prior to training can be really useful, because what it does is says, okay, this nerve here, and this nerve here, they're involved in deadlifting. This nerve here, and this nerve here aren't. So what we're going to do is we're going to turn the volume up to 10 on these, which means we can turn it down to 3 on these, and that's going to make us deadlift better. That's why you should warm up specific to the exercises you're about to do. So doing this pre-exercise will turn the volume up on the nerves which activate, the muscles which are underactive, therefore make them more active for the sessions themselves. Okay? But do it after as well, because that will turn it on. But if you want to get better at squatting, what do? Squat, okay? If you want to get better at keeping the knees out, you keep your knees out. But you have to squat and fatigue yourself. You can't squat and not go to the point of progressive overload. Same thing with your rehab stuff. So many people do these exercises but don't push to the point where their muscles are actually doing enough. Yeah, doing this a couple of times with a band that feels really easy is not going to be enough. Just like with anything, you need to overload to a degree here. Let's broadly categorize these into two areas because we've talked about this being an issue with the Achilles here. Excessive foot turnout. What is tight? The ankles, the Achilles, yep, your ability to dorsiflex. How can we fix that? How can we address that? Yep, to doing PNF for soleus that we talked about. The one where you're lying on the front, knee is bent, foot is up, and you're doing that sort of fella there. Cool?